for maximizing treatment durability, the treat and extend approach with aflibercept.
Very good evening to everyone, and thank you, Pos and Bear, for this talk. Can you please put up the slides?
Slides, please. IT people, please slides.
Yeah, okay. So the topic that I'm going to talk about is strategies for maximizing the treatment durability. So basically it is the treat and extend approach that we use with aflibercept. It's a sponsored talk from Bayer. And that's my disclosure. The slides have been given to me by Bayer, and the cases are from our hospital at Garewala Institute, Chandigarh. So as we know that neovascular AMD is a long-term disease that requires consistent treatment to maintain your visual outcomes. And the recent studies have shown that eyes that resumed treatment after lesion reactivation, they also experience a net loss of minus 3.3 letters from the time of the treatment suspension. So what we need to understand is that the continuation of anti-VEGF therapy, even in stable patients, and you have to titrate their doses in such a manner that the disease is adequately controlled and your patient is also happy. So how the management of AMD has changed over years. Earlier, it used to be, the earlier RCTs that was done, like Anchor and Marina, they used to say that do it fixed monthly. But the treatment burden was a lot. And then the PF4 study came, which said maybe fixed quarterly is also enough. Then CAT and IRVAN, we used to do PRN. And then we moved to the more proactive treatments, which are treat and extend. So what usually happens if you do PRN, that is most of us might be doing that it mandates monthly follow-ups with anti-VEGF therapy. Injection is only given if there is a disease activity. So to reduce this treatment burden and the need for monthly follow-ups, treat and extend has become popular. And in this regime, administration of injections is guided by your OCT findings rather than what your patient is trying to tell you. So I'll show you this classic example of a PRN regime. This is a very smart 75-year-old male who presented to us back in 2020 with a visual acuity of 6/9 with some visual disturbance. And the OCT has a typical feature of a fibrovascular PED with very early subretinal subtle fluid. And this was a typical case of exudative AMD. So at that point of time, we initiated 4 injections of ranibizumab, which were given the first 3 injections, the first 3 loading doses were given, and still the patient had a bit of a fluid, and so he ended up getting the 4th injection also. And by that, the OCT has dried up. Anatomically, he has improved, but vision was still maintained at 6/9. So we decided to stop and observe. So this was December 2020. Things looks back to normal with vision of 6/9, and anatomically, nothing much is happening. But unfortunately, just 3 months later, in February 21, his vision dropped to 6/60, and now he has got a large hemorrhage involving the macula. Fovea is barely spared. Got an OCT done again. Now you have a bad-looking OCT than what it was to begin with. At this point of time, we started him on injection aflibercept, got 3 loading doses at 4 weekly interval. They were good enough to rescue the retina, and the vision did improve back to 6/9 from 6/60 after 5 months and after 5 aflibercept injections. At this point again, it was very difficult to convince the patient that you should continue the treatment. We will try to extend it. As he said, I am absolutely fine and I am better. And 5 injections have done the job. But just 3 months later, from that point onwards, he ended up with another bleed, and now the vision has dropped to 3/60, underwent a PPV with subretinal TP and gas. We were able to rescue something. Vision was only 6/36. So what happened basically was, even though he was treated with 3 ranibizumab, 5 aflibercept, 1 PPP, but the visual result was absolutely bad and poor. So that's the reason that we need alternative, safer, and effective treatment regimes so that we should not end up in such situations. And here comes the role of treat and extend, where the main understanding is that you should maximize and maintain the visual acuity benefit for all of your patients. You should titrate the treatment intervals to match the need of your patients. And at every monitoring visit, the patient has to be treated. You can increase the follow-up interval, and that will make you and your practice more safer. So earlier traditional treat and extend were only allowing it up to 3 months. But now, with these Altair and ARIES studies, which was done using aflibercept, there were 2 groups which were formed. In the ARIES, after giving the 3 loading doses, they had randomized it to 2 different groups. One is the early start of treat and extend, or the late start of treat and extend. In early strats, they basically means that once you have completed the 3 loading doses, you should try to extend the interval by every 2 weeks. In the late start group, they continued doing the fixed dosing of 8 weekly after the completion of 3 loading doses. And after the completion of first year of treatment, then they started to extend it by 2 weeks. Unlike Altair, where they were using 2 weeks or 4 weeks adjustments. So what they figured out is interesting. I won't go through the details of how exactly they maintained, shortened, or extended the interval. So just to give you one brief summary, that if you think that the patient is stable, the vision is maintained, and there is no fluid, you can continue to extend the intervals. The only difference is that when it comes to these newer studies, we have also started to accept a bit of a subretinal fluid. That is a fluid which is 50 microns or less. Still, you can put it as, seems okay, and you can still extend the intervals, which were never used to be the case before. And the end results, what they showed, was that around 60% of the patients were able to extend their intervals by 16 weeks, which was commendable. Even the real-world patients with neovascular AMD, they can also achieve outcomes that were comparable to these randomized trials with aflibercept. This is a classic example of how we treat in treat and extend. If you look at the first picture up over here, this is a fibrovascular PED, a large amount of subretinal fluid. So you start with 3 loading doses. This was baseline, 4 weeks, and 8 weeks. By 8 weeks, the retina has dried up, the PED is persisting. So you continue to treat even after completion of 3 loading doses. And now you should call the patient at 6 weeks. When the patient comes to you at 6 weeks, you should still give an injection. Since your OCT was good enough, there was no fluid, his vision was maintained, give an injection, but next time call him at 8 weeks. When he'll come at 8 weeks, do your OCT scan again and make your judgment. Again, the OCT looks pretty good and dry. So inject, but call him at 10 weeks. Once he comes back at 10 weeks and you do your OCT, what you see, okay, that now a bit of a subretinal fluid has bounced back. So probably this patient requires it at 8 weekly interval at this point of time. So you should not try to extend it further, so take it further down. Do we have still 1 minute? This is my last case. This is a 3/60 visual acuity at presentation with a large subretinal hemorrhage. We thought it could be IPCV or wet AMD, got an OCT macula done, typical thumb-shaped large PEDs at mixtures of subretinal hemorrhage and subretinal fluid. Thought of doing a PPV or an option of a TPA gas or an anti-VEGF injection. Patient ended up choosing an aflibercept injection. And 4 weeks later, there was a breakthrough bleed, and it looked worse than what it was at presentation. At this stage, we advised her to undergo a pars plana vitrectomy. Patient refused it, continued with anti-VEGF injections, and just 3 injections given every 4 weekly. The breakthrough bleeding was there, but the fovea looks a bit better. And that is how her OCT looks after the first 3 injections. So 12 weeks later, there was a bit of a fluid, bit of a vitreous hemorrhage that was still floating around. So decided to re-inject again. This time patient refused, thought to go back to ranibizumab injections. From September till, for the next 7 months, she got 5 ranibizumab injections. So in January, she thought, okay, let me just shift back to something better off, and shifted to aflibercept, continued with treat and extend. And that is how, this is from our EMR, if you can go back and see that in 3 injections in 21, 22, 2, 2, 2. So if you're maintaining a patient on just 6 monthly injections of Eylea, nothing like it. And this is our last visit, which was 7 years follow-up in May 2025. That's how our OCT looks like. Still a bit of a subretinal fluid floating around, but all we are doing is maintaining her on these Eylea injections, and vision was maintained at 6/12. So just to conclude, visual gains in patients with neovascular AMD has been maintained in these long-term follow-ups up to 5 years. And 60% of the patients were maintained at interval of 12 weeks, and 40% can achieve an interval of 16 weeks as well. So that is what was important. Thank you.
Thank you for the wonderful presentation. My one query is that after 3 injections, What do you suggest, that you see the subretinal fluid or you see the visual acuity? How do you decide when to inject and extend?
So if we are doing treat and extend, an OCT is the one marker that we have to follow. Visual acuity, it has to be stable, yes. If the visual acuity is dropping, then you need to reduce your treatment. You cannot extend it further, that's for sure. But OCT is one marker that you have to rely on. It has to be captured at every visit, and you have to treat your patient at every visit. You can increase your intervals, but use OCT as your marker.
Yes, thank you. So we will be going to the second presentation. Dr. Ajay Kapoor sir, leveraging ultra wide field imaging to uncover the hidden threads in the retinal periphery. Ma'am, please join me on the dais.
Good evening, everyone. I thank the organizers for giving me this opportunity to speak on wide field angiography system. To be honest with you, for whole of my life, my retina career, I had been using a conventional fundus camera with a very small field, and always wanted to have a wide field camera once it was available in the market. But since these machines don't come cheap, so it was only recently that the center could afford to buy one of these, and today I'm here before you speaking about this machine. So as you can see from this image, the traditional fundus camera captures only the central retina, and in order to have a wider view, you need to ask the patient to look right, left, center, up and down, which is a really very cumbersome thing. So today I'm talking about wide field fundus camera by Zeiss, it's known as Claris, and it captures beautiful images even in a non-mydriatic pupil, and we will be talking of color, clarity, and the extent of the images. It's a very patient-friendly machine. Patient can sit very comfortably, and it's very user-friendly. The doctor or the technician who is doing the angiography or fundus photography can also have a very good view on this very wide field screen which is available. And here in this picture, you can see what we see in the fundus with various modalities. The central rectangular slit is what you see on a slit lamp with a 90-degree lens. And with the direct ophthalmoscope is a small circle around the disc. Of course, this is, I would say, not a true representation when you're talking of an indirect or a direct ophthalmoscope, because it's a dynamic process. As you are seeing, you are continuously moving yourself and asking the patient to move the eye. However, if you see that the traditional fundus photography of 45-degree and see the difference between a wide field photography of Claris, which is a very large view, and with montage and ultra wide field, it really captures almost all of the fundus. Here in this picture, you can see all these things much more clearly. So a wide field is 133 degrees of field, and this machine particularly has a true color representation, and we are used to seeing true colors, not the pseudo colors what are available with other machines. And ultra wide field modality gives you 200 degrees of field, and with 6 images montage gives you 267 degrees of field, which is really very large field, and you can capture all the dangers which are lurking in the periphery. And even the anterior segment colleagues who will be using this machine can really diagnose retinal conditions and appropriately refer the patient to their retinal colleagues. So this slide tells us what all the machine can do, from external eye photography to color photography to FAF, which is fundus autofluorescence, and FFA, fundus fluorescent angiography. And their technology of precision focus makes sure that all the areas are in focus. You don't need to manually focus it, which is again a very big advantage. Again, older machines we used to adjust the brightness, because once the dye starts leaking or pooling, with the same level of brightness, you get really very bad overexposed images, but not in this machine. So here you can see that in the initial early phases, you can see the dark occluded vessel, and as the dye leaks more, there is no overexposure, there is no bright fluorescence, it's a normal thing. And here is the retinal case of retinal detachment, in which you can see the extent of detachment. And recently, sharing your personal experience, I was not available in the center where I work. The anterior segment colleague, he clicked a photograph of a patient, and he sent me the picture, and he had already diagnosed the case as having retinal detachment, which he would not have diagnosed on direct ophthalmoscope, which he usually uses. And in earlier days, I used to tell them to send me pictures by asking the patient to look up, down, and like this. Now in one image, I could plan my surgery sitting 200 kilometers away. Here again, case of retinal detachment. You can see a beautifully captured HST superiorly, and on the other images post repair. In diabetic retinopathy, you can capture the images of macula as well as the periphery where there may be subtle neovascularizations. And again, the beauty of this machine is as much as you may magnify, there is no pixelation. So you can have things, a neovascularization which is in the periphery as well as macular edema or leaking microaneurysms in the macula, which you can simultaneously photograph and document and show to the patient. This image shows very well done PRP with a multifocal spot laser. See a small hemorrhage in one of the quadrants, one does not miss diabetic retinopathy, you can easily diagnose. And these images show comparison between the competitor, between other machine available in the market. You can see this machine with true color is really more appealing to the eye, and diagnosis will be much more easier. Similarly, in this case, you can again see these images. So this is a fundus autofluorescence picture. Again, comparison of clarity. A picture of CRO, you see the whiteness on the true color image is what we are more used to seeing. And here in the again other machine, there is a lot of eyelashes which come into the play, but not in this machine, and you get beautiful pictures. So this is a case of branch retinal artery occlusion. See this pallor easily seen to what extent it is going in the periphery. And these are the fundus fluorescein angiography images. So even for the glaucoma colleagues who want to photograph the disc, this machine comes into play because there is no pixelation and disc will be captured beautifully, and other signs of glaucoma too can be analyzed on a color photo image. So drusen's, which optic disc drusen's, which give rise to pseudopapilledema appearance, again on fundus autofluorescence, diagnosed very well with this machine. So here you have a PDR case with Irma's. I would have liked to see, an image with Irma's magnified image, but that's not available. But with this wide field FFA image, you can see small early neovascularizations, and patient needs PRP. So old case of CRVO with macular edema, you can see the leakage in macula in the center with dilated tortuous vessels. And if you see a lot of capillary non-perfusion in the periphery, then the patient needs an laser also. Here is the case of BRVO. So now here is what I was talking of, that you can magnify the image from the complete to macula only, and there will be no pixelation. So you can see this is a case of PED with subretinal hemorrhage, serious detachment is there, and this machine, because it captures things beautifully, you can even see a hyperreflective polyp, which is responsible for this. A case of Eales disease, very common in our country. See the level of capillary non-perfusion and the contrast which provides you, which lets you see the non-perfusion, and treatment can be planned accordingly. A case of FEVR, which we may not be seeing in everyday life, but again periphery ischemia and tortuous blood vessels with new vessels is easily seen. So here's a case of diabetic macular edema with peripheral non-perfusion. This is a case of CSC or CSCR, as we know, and these diseases like CSR, where you can see leakage in traditional FFA, you cannot see it on Octa images. So here comes the role of FFA, and for old timer like me, FFA is yet not dead. It has a lot of role to play in my OPD. Thank you.
Very well shown pictures. Just a quick question. So it's basically one machine which is giving you all the options, right?
Yes.
And any option of a video fluorescein angiograms available?
No.
Like, can you? Just to add on to one point that Sir has very clearly pointed out, that fluorescein angiograms are not outdated yet, especially in cases of CSCs, and even in uveitis, fluorescein angiograms still has a role, and you can't completely rely on Octa images in those cases.
So the next presenter is Neetu Gagneja. She will speak on macularosity. I will request Dr. Ajay Kapoor, sir, please.
Good evening, can I start? This is a very basic presentation on the interpretation of the macular OCT. So OCT is an imaging tool everyone knows, and it gives the cross-sectional images of the human retina. And this is the most commonly used machine, that is Series 500. And these are the various layers which we see on the OCT. And previously we used to see only under the microscope. Now with the help of OCT, we are seeing all the layers in vivo. So it was started in 1991, and in 2007, spectral domain OCT came into picture. And it's a non-contact, non-invasive imaging technique used to obtain high-resolution cross-sectional images of the retina. And it gives the qualitative analysis and quantitative analysis, that is the retinal thickness and the volume of the nerve fiber layer thickness. So these are the various scanning protocols, line scan and the macular scan. The various line scans are the single line scan, HD line, HD register, and the HD one line scans. And macular cube scan, most commonly we use it 128 into 512 because it has a better resolution than the 200 into 200. Normal macular layer which are more important are the vitreoretinal interface, inner retina, outer retina, choroid, and the sclera. So vitreoretinal interface, we'll see vitreous as a hyporeflective space, that is black, and premacular bursa, that is hyporeflective space in front of the macula. And hyperreflective continuous line is seen as a posterior hyaloid. In a retina, we see hypo and hyporefractive bands, and the layers which are axons perpendicular to the light or contain synapses appear hyperreflective, and the layers which only contain nucleus appear hyporeflective. Outer retina, the most important is RPE Brooks membrane complex and ellipsoid zone. So directly coming to the macular cube, this is the most common picture which we see in day-to-day OPD. And the first is the fundus image showing ILM to RPE retinal thickness map overlay. And the second is the slice navigator. Then third is the ETDRS grid retinal thickness values from ILM to RPE as compared to the normative data in 9 sectors. Then fourth is the OCT fundus image. Then the various are the fovea finder, horizontal crosshair line, and the vertical crosshair line. And the 11th one is the macular parameters compared to the normative data. So these are the 5-line raster scan. Directly coming to the common retinal conditions which we see, hyperreflective and hyporeflective. Hyperreflective, most commonly which we see are the drusen, CNVM, hard exudates, hemorrhage, ERM, and hyporeflective are the intraretinal fluid and subretinal fluid. So the most important is to identify ellipsoid zone and RPE Brooks membrane. So we have to identify this. These are the most common condition which we see in day-to-day OPD. So these are the common diagnoses which we see. Like this is the first one is a compact. All the retinal layers are squished into one, and this is a normal OCT scan. And this is the intraretinal fluid, speckled in appearance, mainly seen in DME. And this is diffuse outer, which is seen in most of the time, vascular occlusions, empty spaces we see in the post-op CME, and the subretinal hyperreflective membrane or material, and subretinal fluid, which is seen in inflammatory CNVM, and PED along with SRF and IRF is seen in wet AMD. So before we get into all this, we need to identify RPE and ellipsoid zone. So in this picture, as we can see, the RPE is seen by the red arrows, and the hyporeflective area between the two is the SRF, which most commonly we see in the CSCR. Now, in this case, in this we identify the RPE and ellipsoid zone. Hyporeflective space indicated by the star is SRF, and PED is also seen is any elevation in the RPE. And subretinal fluid and PED. So again, this is more important because we'll be able to make out by seeing the OCT only whether it is an active CNVM or it is an inactive CNVM. Subretinal, if it is amorphous, we cannot make out, and then it is a sign of active CNVM. And if it is a consolidated, it is most of the time it is a sign of inactive CNVM. So, and outer retinal tubulations are, these are the signs of chronicity of the disease. And this here I'm normally seen as a hyperreflective band attached to the inner retina. This is the most commonly seen in full thickness macular hole. So this is OCT of one of my patients of the full thickness macular hole, and this was one of my patient who had a vascular occlusion, and post anti-VEGF, she improved with one injection, and now she is following up. And this was again DME, and post ILIA it improved drastically. And this was a case of CSCR. Thank you.
Yeah, very nicely presented. It was such a vast topic, so it was very difficult for you to cover all. And just one point I want to highlight to you is that every hyperreflective space that you see in the outer retina is usually not subretinal fluid. There could be pseudo-SRFs also. So these are just common things that you have presented. There are patients with vitaliform diseases and things like that, which are not really even non-exudative pigment epithelial detachment. So you really don't need to think of them as a fluid. It's never the actual fluid. And one more point is that in your practice, don't look at the printed copies that the patients bring to you. Always go back to your machines and look the live scans, because so many times you will miss a laminar macular hole to a macular edema and vice versa.
Yeah.
Thank you.
Actually, this is the point I too was about to tell, that especially for the delegates, that usually what happens is that anterior segment colleagues who have OCTs, they just ask the technician, iska OCT kar lao. And then a very badly printed report is sent to a retina specialist, and when the retina specialist asks the patient to get a new OCT done, the patient thinks that we are greedy and we want to make some money out of it. But kindly look into a machine. One line may not be sufficient, and teach your technician. Once you get up from your chair, go to your OCT room, there are 3 benefits. Number 1, your technician will learn where to do the OCT, where the pathology is. Second, you will get a better pictures for your patient. Your patient will benefit. And third, it will be beneficial for you, because सारा दिन का जो chair time है वो कम हो जाएगा. You will be walking, so जो belly पे fat है वो कम आएगा.
So the next presenter is Dr. Abhijit Singh. Abhijit, Understanding Octa.
Good afternoon, everybody, and thanks to AIOC's scientific committee for giving me the opportunity. This is a vast subject. I just touched the salient points. So this is a reflected low coherence light over time, and repeated B scans we do, and it analyzes changes in amplitude and or phase signal. Basically, it differentiates scattering signals between stationary and moving tissues, and images of microvascular flow it does. There are the algorithms like phase-based, intensity-based, and mostly these mixed signal-based algorithms. And you can see the types are usually sweep source-based, or SSOCT, or spectral domain-based. So OCTA has some advantages. It is in vivo optical biopsy, and dye not needed, so it is safe for elderly, in pregnancy, and it can be done repeatedly, and definitely it does not have any allergic problems, and it is a faster procedure, and resolution is 5 to 8 micron. Excuse me. So limitations are small area. It is initially it is 3 into 3. Now it is 12 millimeter into 12 millimeter. There will be some artifacts which we have to rule out, like motion artifacts will show it, segmentation error, overlying projection artifacts, inconsistency in disease settings. I'm not going to tell about that because my esteemed speaker before this described this. So this is the superficial vascular complex and the deep vascular complex. Any machine if you go, and they'll show you the avascular layers, the choriocapillaries and the choroids. So superficial vascular complex consists of the nerve fiber layer and superficial capillary plexus. A deep vascular complex consists of intermediate layers and the deep capillary plexus. The deep capillary plexus supplies your, and the intermediate basically the inner and outer layer of the inner nuclear layer. So the superior capillary plexus is basically primary arterial pole. The blood enters through that, and the deep capillary plexus is the primary venular pole. So this is a retinal flow image. If you see the A and D is the full retina, and B and E it is the superficial plexus where it is cutting is given. C and F, if you see the right hand side, it is a deep plexus. G to J, avascular zone, H to K choriocapillaries, and the last 2 are the choroidal vessels. And choroidal circulation is slightly difficult resolution due to RP attenuation and HDOCT. And then the shadow artifacts, projection artifacts, and also segmentation artifacts are there. So these are the different OCT machines. If you see, all are very good. Price-wise, there are lots of differences. Only the Topcon machines now also uses the sweep source things. All other usually uses using the spectral domain. And the algorithm also is slightly different in all the machines, you can see. So the interpretation we came. This is the most important. Anything abnormal in auto segmentation, first we see, then which segments, then correct segmentation done by the machine, then the location, then the artifacts, and then the nature and flow of vasculature. In OCT angiography, you cannot rely on any print. You have to go to the machine, you have to spend about 10-15 minutes, and then you can interpret. Otherwise, no way. In fact, the technician will do a faster job taking up the photos than you will spend your time. So there are a few of the OCT examples of the OCTA, acute central retinal artery obstruction. You can see the superficial vascular complex and the deep vascular complex. You can see the DVC is much more affected than the SVC. And this is the RVO. RVO, you can see, is a composite 12x12. You see the SVC is much less, but the DVC, as we told, because that was the outflowing channel, that gets blocked first, and then it comes back to the SVC. So it is showing much more capillary dropouts, flow deficits, which we call. And the diabetic retinopathy, if you see, the small arrowheads we are showing, this is the microvascular anomalies, and the blue arrows are definitely the vascular dropouts. And this is the NVE, which can be combined with the B-scan OCT, and if you see, this is the arrowhead showing a vessel. On the pre-retinal surface, the unphased OCT showing definitely it is NVEs, and the B-scan showing the flow overlay. So you can find out it's the NVE. And this is the type 3 neovascularization before and after few anti-VEGF injections, you can see the left side. And a type 1 macular neovascularization. If we manually adjust the segment, and this is a different machine basically, type 1 macular neovascularization vessel and 618, and you can see that with the treatment, you cannot see the thing, but fibrovascular PED still remains there. There is, with multiple injection, we have given aflibercept, brolucizumab, and ultimately faricimab. Every 2 to 3 monthly we give faricimab, and now it's stabilized, you can see. And this is so, and the angioretins, the optoview machines, some photos are there, you can see there. And we'll go to the, this another patient, yeah. So you can see here, if you see this one, we'll see there is a abnormal blood vessels, but segmentation, see, it is wrongly done, the blue head. And if we correctly segment, make it a segmentation, then it gets vanished. So this is a segmentation artifact. And here you see the white lines, and you see the duplication artifacts with the middle photo, the blue arrow, and then the stretch artifacts are there. These projection artifacts don't go fully, basically. And you will see here, the dark vessel artifacts are there. It is there in the small white arrows. And the oval things they have shown here, you can see the red colored blood vessels, which is going through all the layers. So it is showing into the up layer like the deep vessel complex, that is still vessel is still there. So we have to see in the machine basically and see the blood vessel markers also in the SD OCT, the lower down B-scan OCT where you see 2 dimensional, and then you have to compare with the up, and then you can reach a diagnosis, okay, the vessel is there or not. And shadow artifacts, and thank you. That's all.
Very well covered, sir. Just a quick question to you. In your routine day-to-day practice, how often are you using these octas? And secondly, do you use them in monitoring your diseases as well, or just for the initial diagnosis?
No, nowadays we stopped FFA, except very few cases of maybe uveitis, with where we do the ICG also concomitant. All the times we do octa, and it takes your time. It's not like normal OCT. In fact, FFA interpretation is faster than, I should say, the octa, because the more data we are getting, the more it is becoming problematic in deciphering. And the second question, madam, what you asked?
That are you using octas to, suppose if it's a case of an exudative AMD, are you still relying on your OCT images vision, or are you still following up on your octa images and seeing your vascular complexes to decide on the need for an anti-VEGF?
So whatever we do, madam, very honestly, first we do the octa instead of the FFA or ICG, and then we start the treatment, and that time we do the SD OCT or the 2D OCT. and then we follow up with the 2D OCT. Suppose when we plan that in 2D OCT vision is, it is not showing any change, vision is stable, and then we are getting one, trying to reach one decision that whether we call the patient slightly further away or not, that time we do octa maybe after 3-4 months. Otherwise, we usually do it 2D OCT only. Follow up.
Thank you.
Thank you.
Right.
Dr. Pooja Sinha, is she here? Then Sonia Singh, she will speak on macular telangiectasia type 2, clinical insights and management. Dr. Gaurang Sehgal is here. Dr. Anuradha, Tinku Bali ma'am.
Good evening, everyone. So I'll be talking about macular telangiectasia type 2. Also, as we all know, it was known previously as juxtafoveal or parafoveal telangiectasia, initially described by Gass and Oyakawa and later on termed as MACTEL2 by Yanussi. It is a bilateral neurodegenerative condition affecting the macula with secondary vascular changes, seen in patients above 40 years of age with a prevalence of around 0.1%, and the disease progression varies between the two eyes. It has been seen that most of the cases are sporadic. Genome-wide association recently published by MACTEL project has identified susceptible loci affecting the serine and glycine metabolism, which leads to Miller cell dysfunction and vascular abnormalities, leading to retinal ischemia and atrophic changes because of the accumulation of toxic deoxysphingolipids, leading to photoreceptor and vascular damage. Early stages may be subtle with not much of clinical sign. Patient may be asymptomatic. Gradually, we start seeing fundus findings and imaging findings. Advanced disease may have neovascular complication and atrophy leading to permanent loss of vision. There have been certain ocular and systemic associations reported with these conditions by some case reports like drusen, ERM, full thickness macular hole, diabetes, hypertension, etc. Gass and Bloody way back in 1993 gave a staging system, divided them on basis of clinical and FFA findings. Now, recently, MACTEL project, which is an international multi-center initiative, they are working towards the pathogenesis, natural history, and treatment options for this condition. They gave a modern classification system using multimodal imaging, which is, they have labeled as simple MACTEL classification, which is a practical clinical staging system based on OCT, dividing them into the condition into 0 to 6 grades. It correlates well with visual function and prognosis, and it is easy to use in our clinical practice. Coming to clinical features, initially patient may have mild or no reduction in binocular BCVA. Gradual, progressive, slow loss of visual acuity may happen, but visual acuity is not the only dysfunction which they have. They may also have difficulty in adapting to illumination changes. Reading dysfunction will be the most common complaint you'll hear from these patients because of the central scotoma, especially when the left eye is affected. The reading speed is significantly reduced in these patients, which affects their daily activities. Coming to fundus findings, there's an area called MACTEL area, which is an oval-shaped area centered around the fovea. You may see loss of foveal reflex, retinal transparency may be reduced, leading to retinal graying. Parafoveal capillaries may show telangiectatic changes. Crystalline deposits, pigment deposition, right-angled venules, later on complications like macular holes and neovascular complexes. Coming to OCT, OCT has become a very important tool, both in the diagnosis and follow-up of these patients. You may see initially as these hyperreflective middle layer altered foveal contour. Inner and outer retinal hyperreflective cavities may develop, which may later coalesce and form ILM drape, crystalline deposits, outward bending of inner layers, or also called a collapse of layers, ellipsoid zone, and external limiting membrane disruption, retinal thinning and atrophy, pigment migration to the inner retinal layers, presence of subretinal membrane and macular hole as late-stage complications. FFA has been considered as a gold standard for diagnosing this condition because it can pick up early changes which our normal investigation modalities can't pick up. So it may show temporal capillaries leakage in FFA. SRNVM can be picked up on FFA easily. Autofluorescence findings are seen in 95% of these eyes. Initially, increased autofluorescence in the temporal parafoveal area, and later mixed or patchy pattern may be seen because of the pigment RPA atrophy and cystic changes. OCT angiogram is a new tool in our box. So initially, deep capillary network is the one which is affected. Later on, superficial network also gets affected. You may see telangiectatic vessels, reduced vascular density, FZ irregularities and enlargement, vascular dragging temporally, and right-angled venules. You can pick up neovascular membrane in the outer retina, and also quantitative indices like FSZ measurement and vessel density quantification can be used for research purposes. Coming to treatment, there is no cure to this condition. Based on presence of SRNVM, it can be divided into non-proliferative or a proliferative stage. Non-proliferative stage, although various treatments have been tried, but the recommended approach is still observation, hamster grid monitoring, and routine follow-ups. Now, recently, in March 2025, FDA has approved CNTF implant named as Incelto. The 24-month efficacy data of this implant has shown up to 56% reduction in photoreceptor loss and a significant EZ loss in these eyes. It is supposed to work for around 14.5 years. It is an implant which is surgically anchored at the pars plana with a titanium loop. Mechanism is still not fully understood and is still not available commercially. Coming to proliferative, which is an important cause for sudden loss of vision in these eyes, can affect 2 to 14% of the eyes and requires treatment with anti-VEGF injection. You should always have a suspicion for this complication if you see a subretinal hemorrhage, retinal thickening, or visible macular membrane. Diagnosis can be confirmed by FFA, OCT, and OCTA. Anti-VEGF therapy helps by reducing leakage, reducing central retinal thickness, and it can often stabilize vision, but that happens in only around 30 to 40% of the eyes, as reported by various case series. The outcome is seen better when the baseline lesion is located parafoveally. If it is chronic, the outcomes are not very good, and scarring also reduces the outcome. Though there is no head-to-head data to compare various anti-VEGF agents, you can choose the anti-VEGF agent depending upon the availability and the cost factors. PRN or individualized regimens can be used. So best outcome is seen in early treatment, extrafoveal lesion, and minimal fibrotic changes. Macular hole is also one of the complications which can rarely happen, but since it is a degenerative condition, the outcome with pars plana vitrectomy are not very exciting, and it is not routinely recommended. Now, so to sum it up, these patients need close monitoring and follow-up. Even if you're treated with anti-VEGF, they can always recur, so you need to monitor them closely. Active M&V protocol should be initiated on your vascular finding, and the goal is to stop leakage and preserve and stabilize vision. This should be explained to the patient. Patient should be counseled well and set up with the real expectation. Thank you very much.
I think patients who are to undergo cataract surgery, it's very important for them to tell them about this condition.
Yes, sir.
So anterior segment surgeons who are not showing the OCTs to retina surgeon, where retina surgeon is not available, they need to know the signs of early signs, and that's it.
So the next speaker is Dr. Gaurang. He will speak on peripheral retinal degenerations, when, what, and how to treat.
Good afternoon, everyone. I'd like to thank AIOS for giving me this opportunity. Today, I'm going to speak on peripheral retinal degenerations, when, what, and how to treat. So the presentation plan is going to go in 3 parts. In part 1, I will describe the peripheral retinal degenerations which we have. In part 2, I'll like to elaborate when to treat, and the last part would be recommendations for patients who are undergoing any refractive or cataract surgery. So part 1, the different peripheral retinal degenerations. So first of all, we have to understand what do we mean by degeneration. Degeneration means loss of structure or function of a cell in a tissue or organ anywhere in the body. And when this loss of structure or function is happening in the retina, we call it as a retinal degeneration. Now these retinal degeneration can either be on the posterior pole or in the periphery. If it's on the posterior pole, it's commonly seen in macular degeneration such as ARMD. Now classification based on location, the degeneration can be either vitreoretinal, intraretinal, or chorioretinal. Snail track, lattice, and retinal tears are vitreoretinal. Retinoschisis, snowflake, WWOP, DWOP, atrophic retinal hole with or without operculum are intraretinal, whereas paving stone degenerations and peripheral occlusions are chorioretinal degenerations. Now, why are they important? Because usually they are located anterior to the equator, they can be easily missed, can be associated with atrophic retinal breaks, and can develop dynamic retinal tears which can lead to RDs, and of course all of them predispose a person to rheumatogenic RDs. Now the common ones are, the first is a snail track degeneration. Now this looks very similar to what a lattice looks like because it is of the same size, shape, orientation and location as the lattice. It can also be associated with a retinal hole. Now I have ran a OCT through the degeneration of, which is the snail track 1, and if you can see here, there are irregular retinal surface, and you can see hyper-reflective dots on the OCT, which are basically lipid deposits. Whereas irregular retinal surface, also you can see in the OCT, and if you can see the scan, there's an atrophic retinal hole with a bit of SRF, and the surrounding retina is also very atrophic. So this is OCT which is going through the lesion. So the vitreous changes in a snail track degeneration are the vitreous liquefaction noted, and there is no dense vitreoretinal adhesion which is seen. So this is how we basically differentiate. Second is the lattice degeneration. So a lattice degeneration is basically present in periphery. It can be superior temporal, superior nasal, any part of the retina it can be seen in. The third is a retinal hole. A retinal hole is a small hole. It can be present. It is total loss of structure. The whole retina is missing, so it can or cannot be associated with the operculum. Usually we see a retinal hole with the operculum. It can be atrophic also. Now third part is a dynamic part which I'm talking about. That is a retinal tear or a horseshoe tape tear. If you can see, this is basically when the PVD induces from the posterior pole and goes towards the periphery. It's a dynamic break, it's not a static break. So the vitreous pulls and causes a horseshoe tape in the periphery, again predisposing for retinal detachment. Third is a snowflake degeneration, the next one. The snowflake, these are white crystal deposits, which are crystal-like deposits which are seen in the periphery. Paving stone degeneration is a type of chorioretinal degenerations, again seen in periphery. These are basically chorioretinal degenerations, as I told in starting off my talk. Now there's something called as WWOP, which we call white without pressure. So if you can see in the temporal periphery, there's a region of whiteness which is present, beautifully captured on the ultraviolet field imaging. Now there's something which is called as a dark without pressure. Now these are dark areas on the retina. WWOP are white areas on the retina, and DWP are dark areas on the retina. Without pressure means that these lesions are seen without indentation, without applying any external pressure to the globe. Now what causes a RD in an eye with peripheral retinal degenerations? Basically, it is a posterior vitreous detachment. Unless the vitreous is well formed, there is no posterior vitreous detachment, the risk of RD is pretty low. But once the retinal PVD has happened, of course, there is a very high risk for retinal detachment. Now, there's an acute if there's acute symptomatic PVD, there's acute onset of flashes and floaters, which can be seen. And usually, patient comes to us that suddenly I'm seeing so many floaters in front of my eyes. Now, acute PVD can be associated with either vitreous hemorrhage, retinal tear, or an RD. Repeat retinal examination. Once the patient walks into your clinic and says that he or she is having floaters, and you make a diagnosis that the PVD has started, again examine after 4 to 6 weeks. So there's to make sure that the PVD has happened uneventfully and has not left a mark in the eye. Now, when to treat? So first you have to see what is the lesion and what are the vitreous changes surrounding the lesion and what are the risk factors in the patient developing for an RD. Now the recommendations for screening and management, do we treat all the lesions, all the 8 lesions, 9 lesions I talk about, do we treat all of them? No, that's not the case. So this is I have taken up from AIO. Basically it's more on the Western data. We are still lacking a study on Indian data, which basically says that all symptomatic and asymptomatic horseshoe tape tear, HSTs, operculated holes, lattice degeneration with holes and atrophic holes is treat promptly. So anything which has a hole, anywhere where the retina is missing, you have to treat. If it's HST, you have to treat. All symptomatic lattice degeneration without holes, treatment is usually recommended. So I was saying you can treat if you want, it's the surgeon's choice. All asymptomatic lattice degeneration without holes, pigmented lattice degeneration and atrophic holes, they can be observed. Whereas eye with atrophic hole or lattice degeneration where the fellow eye has already developed retinal detachment, is better that we treat asymptomatic lesions in the other eye also. Now we have our refractive colleagues and our cataract colleagues who usually refer us for peripheral retinal examination. So once you have spotted out there's a peripheral retinal degeneration which has to be treated like with a hole or a HST, then I would recommend that you do a barrage laser and wait at least 7 to 14 days following the laser photocoagulation, and then you go and plan a refractive surgery. I strongly recommend that there should be retinal re-examination as early as 2 weeks for the surgery to make sure that the laser marks are taken up well and there is no risk of retinal detachment in future. So the take-home message is that patient undergoing cataract or refractive surgery, please look for periphery. Prophylactic barrage photocoagulation is the way to the predisposing degenerative retinal lesions at least a week before the surgery. Retinal examination should be done at regular intervals. Development or progression of PVD, retinal tears, RD, and macular pathologies is very less documented. Thank you.
Yes.
It's a very nice talk, thank you. But few points I think will differ that detachment is associated with the vitreous condition, not the PVD. Because lots of times we will get detachment with atrophic breaks, no tear. And we have to induce the PVD while doing surgery. Number one. Number two is that all holes we don't laser. AO is not recommending that till the latest things. All symptomatic tears and asymptomatic tears also they are telling laser, horseshoe tears. But all holes, the peripheral holes, asymptomatic holes, by chance you are on examination, you are diagnosing, they are not recommending laser.
They are saying it depends upon this can be treated. This is what they have said for
And
atrophic holes.
Not needed clearly. And number two is there's some areas where you can treat, like the aphakia is there, and the other eye detachment on some vitreoretinal degenerations are there. And another thing you did not mention, FEVR. So those areas you have.
Even for GRT, if one eye has developed a GRT, we usually go and do laser for the other eye also.
Where you will laser? In GRT, one eye you get laser.
Other eye, if there are asymptomatic degenerations. That has also been recommended. Yeah.
So all cataracts also don't need treatment, they're being treated. So it's better to treat a retinal hole rather than treat an 6-9 cataract.
Thank you. I will request Dr. Anuradha now for retinal toxicity in chronic hydroxychloroquine use, clinical insights and evolving perspectives.
Good evening. Let's take some time today to reacquaint ourselves with the nuances of hydroxychloroquine therapy and its effect on the ocular system. Hydroxychloroquine is an anti-inflammatory drug, an effective alternative to chloroquine with a presumed smaller adverse effect profile. However, as the drug found its use for a variety of chronic systemic disorders, it was also found to be associated with a plethora of adverse effects, most sinister being drug-induced retinopathy. It is widely used in rheumatological practice, with systemic lupus erythematosus, rheumatoid arthritis, and Sjogren's syndrome being the commonest indications. The drug is also used in various dermatological, oncological, and pediatric conditions. The drug was also experimented with during the research for effective treatment for COVID-19 pandemic. The effect was found to be inconsistent, and a requirement of a dose which was much higher than routine raised concerns regarding potential early onset adverse effects in the future. Contraindications of hydroxychloroquine are few but important, including known hypersensitivity, pregnancy, pre-existing retinopathy, and concurrent use of other drugs like tamoxifen, which cause retinopathy. The dose of hydroxychloroquine needs to be carefully calculated. Earlier, ideal body weight was used for dose calculation, and a dose of 6.5 milligram per kg per day has been suggested. However, it may not always be possible to calculate the ideal body weight of all patients, especially in a busy OPD setup. Also, it is fraught with the risk of overdosing in very lean patients. So now an actual body weight dosage is used with 5 milligram per kg per day recommendation. It is also associated with risk of overdosing in obese or shorter patients. So for all practical purposes, a dose of 200 to 400 milligram per day is considered safe and effective. The adverse effect profile can be divided into ocular and systemic. Ocular side effects can be non-retinal, which are generally dose-related and transient, or retinal, which is irreversible and progressive. The drug can affect almost all organ systems of the body and rarely can cause hypersensitivity reaction as well. Non-retinal adverse effects are rarely seen and include accommodation defect, transient corneal edema, cornea verticillata, and reduced corneal sensations. Retinal adverse effects range from deficient color vision, visual field defects, pigmentary changes in macula and peripheral retina, arterial attenuation, and optic atrophy, comprising the spectrum of progressive hydroxychloroquine toxicity. Retinopathy is by far the most researched adverse effect, initially considered rare, with widespread use of the drug and evolution of specialized investigative modalities in ophthalmology. The prevalence has been found to be higher, albeit variable, likely due to underreporting. A milestone prevalence study was conducted in 2014 at Johns Hopkins Institute by Mellis and Marmor. It showed wide prevalence depending on dose and duration of drug use. This study formed the basis of recommendations of the American Academy of Ophthalmology in 2016. Other studies, as mentioned, have shown variable prevalence worldwide. A study conducted by us in 2021 among 100 patients over a period of 1.5 years showed a prevalence of 15%. The risk factors for retinotoxicity are dose and duration of drug, although low dose over a prolonged period of time has also been associated. Pre-existing ocular pathology such as glaucoma, rod cone dystrophy can confound the results of investigations and also influence the progression of retinotoxicity. Some drugs like tamoxifen are independently associated and aggravate hydroxychloroquine-induced retinotoxicity. Concurrent hepatorenal disease, use of cytochrome P450 inhibiting drugs and genetic factors have been associated. Elderly patients and women have been found to be more predisposed. HCQ is a lysomotropic drug which is an inhibitor of autophagy. It binds to non-pigmented tissues and melanin in pigmented tissues. In the eye, melanin is found in uvea and RPE where it has important antioxidative functions and provides protection against light toxicity. HCQ, when bound to melanin in the RPE, specifically inhibits the cellular uptake of all transretinal, which leads to phototoxicity. HCQ retinopathy is mostly discovered during screening. The commonly encountered signs are visual field defects, macular and peripheral retinal pigmentation with arterial attenuation and optic atrophy, in advanced cases giving a rod cone dystrophy-like picture. Color vision defects are inconsistently seen. A very rare sign is cystoid macular edema. Some atypical presentations have also been reported, including accelerated and asymmetrical retinopathy. Coming to effective screening methods for HCQ retinopathy, spectral domain OCT macula has been the cornerstone for diagnosis. It shows involvement of outer retinal layers and relative sparing of inner retinal layers, which may cave inwards depicting the famous but not pathognomonic flying saucer sign. Advanced disease shows severe thinning of all zones. These are the OCTs of some of the patients from our study. They show a relative sparing of foveal center till advanced disease. The characteristic flying saucer sign-like picture is also noted in the middle photo. Perimetry enables early detection of asymptomatic scotomata. However, it is important to note that no specific pattern of field loss can be expected, and fields may not always be consistent with other findings. These are some types of field defects that can be seen during screening. Here we can see a symmetric retinal thinning on OCT in both eyes with similar clinical picture, but with grossly different visual field findings. Fundus autofluorescence has been found to reveal parafoveal hyperautofluorescence with foveal sparing due to accumulation of lipofusion within RPE liposomes. A bullseye maculopathy may be detected on autofluorescence before manifesting clinically. As seen in this picture, the pigmentary changes at the macula have not yet taken the form of bullseye maculopathy. However, the same can be clearly demonstrated on fundus autofluorescence. When correlated with OCT macula, bilateral bullseye maculopathy in this patient is associated with severe foveal thinning in all zones. Multifocal ERG has been promoted as an objective method for assessment of photoreceptor function. A 5-ring stimulus reduces acquisition time with comparable results compared to 61 hexagon stimulus. This test is 93% sensitive and 97% specific for HCQ retinopathy. Microperimetry is a combination of visual fields superimposed over fundus imaging over central 20-degree area of fixation. The test is 73% sensitive and 93% specific and is not recommended for primary screening due to low sensitivity. Novel investigations include OCT angiography, modalities of novel OCT analysis, use of adaptive optics and multicolor imaging. However, they have not yet made their way into the recommended screening guidelines. Investigative modalities which were previously considered important but are now outdated include fundus photograph, color vision, Amsler grid, and fundus fluorescent angiography. The best way of detection of retinopathy today is the use of multiple investigations, as no single investigation has been found to be diagnostic for retinopathy. The 2016 guidelines by the American Academy of Ophthalmology are currently followed worldwide. It recommends a baseline fundus examination before starting HCQ, followed by annual screening starting at 5 years of treatment. The Academy suggests OCT and perimetry as primary investigations with ERG and autofluorescence as supportive for diagnosis if available and required. The Royal College of Ophthalmology differs slightly from American Academy in its recommendations. It suggests the onset of screening based on risk factor profile and recommends OCT and autofluorescence as primary tests with perimetry and ERG to be used when both OCT and autofluorescence are not simultaneously positive. There is no treatment for established retinopathy. Sporadic reports suggest improvement in vision and fields after drug cessation. However, this is not universal. Rare cases with cystoid macular edema have been managed with acetazolamide and dexamethasone. However, the primary management remains cessation of hydroxychloroquine and substitution with alternative therapy. Eliminating risk factors, correct dose calculation, screening with discipline, and developing facilities for the same are vital to primary prevention of HCQ retinopathy. This is in fact the need of the hour to streamline screening systems in our country, where hydroxychloroquine is very commonly used in clinical practice. To conclude, irreversible retinopathy makes hydroxychloroquine an important drug subject to monitoring. Careful dosage, risk factor assessment, and disciplined approach towards screening strategies are the only ways to prevent retinopathy in patients with chronic systemic disease. These are some of my references. Thank you.
Thank you, Doctor.
Thank you so much. So one point that you made was, yeah.
Can I ask one question? So
Yeah,
for the screening, I might push to the whole panel also. For the screening purpose, AO recommends 10-2, but for Asian population, they do recommend 24-2 or 30-2. What do you people practice?
I mean, at our center, at baseline, we are doing a visual field 10-2 and an STOCT.
Both.
These are the two ones. Yeah, 10-2.
10-2. Thank you.
Thank you.
Now I invite upon Dr. Tinku Bali for today's last talk of the session, beyond mitigating late complications of venous occlusions.
Good afternoon, everyone. So vein occlusion is the second most common vascular problem after diabetic retinopathy and can lead to irreversible visual loss if not managed at the correct time. So a vein occlusion could be a central or a hemicentral vein occlusion. A branch retinal vein occlusion could be a major branch retinal vein or a macular branch which has occluded. Now, the most common complication is macular edema associated with BRVO, and that is the thing that is most commonly talked about. But there are other facets of vein occlusion that are very scantily studied, and that is something that I'll be concentrating on today. Now, the microvascular abnormalities associated with the branch retinal vein occlusion are these collateral vessels, telangiectatic capillaries, neovascularization, areas of capillary non-perfusion. So whenever you see clinically a patient, you can actually see those telangiectatic vessels, and that is a giveaway that this patient has had an episode of a venous occlusion. So the late complications of a vein occlusion, as we all know, are a retinal or a disc neovascularization, a vitreous hemorrhage, tractional retinal detachment, epiretinal membrane, macular hole, macular scarring, or a retinal artery macroaneurysm. So unfortunately, most of the patients who are treated with anti-VEGF are lost to follow-up after some time, and it's very important to emphasize to our patients that this condition can have late complications, and a longer follow-up is mandatory for such patients. Now, neovascularization after BRVO, about 28% of the patients can develop some neovascularization either on the retina or on the disc. Anterior segment neovascularization is extremely rare, though it can happen in a few subset of patients. So 1.6% would have some iris neovascularization, but mostly it's retinal neovascularization. In CRVO, it's the opposite, where you have anterior segment neovascularization is more common than retinal vascularization. Vitreous hemorrhage is extremely common, and we all have seen the scenario of a patient who had a venous occlusion and comes back 2 to 3 years later with vitreous hemorrhage. So any hemorrhage in a patient, a sudden onset hemorrhage, especially in a hypertensive patient, do keep an old venous occlusion very high on your list of suspicion. And through that hemorrhage, many a times you'll be able to see a white occluded vessel if you look very carefully. And you can also see these squiggly telangiectatic vessels, which are a giveaway that this patient with a sudden onset vitreous hemorrhage has had a prior history of BRVO. Again, this was a patient with a vein occlusion who was treated with anti-VEGF. So the thing is that while the patient is on anti-VEGF injections, these new vessels are suppressed. The patient is not going to have a hemorrhage at that time, but it's later on when the edema has subsided and the patient goes away, comes back to you later on with these new vessels. So what I want to emphasize is that you must keep these patients under a long-term follow-up. So this was a patient who had BRVO, was advised laser, did not get the laser done, came with a vitreous hemorrhage, and just 2 months down the line you see that there's traction that has started to develop over there. So another similar patient, you can see the vein occlusion there. Now this was the patient who should have been lasered. Again, this patient was lost to follow-up, came back with a vitreous hemorrhage and TRD. Now angiography is important in every case of a vein occlusion, but there is a window period where you have to do the angiography. Too early is not advisable because at that time you're not going to be able to get much information because of the hemorrhages that are present there. So the right time to do the angiography to assess the amount of non-perfusion is generally after 2 months when all the hemorrhages are fading. Wide field angiography definitely gives you more information regarding the CNP areas. And retinal neovascularization generally occurs in 36% of eyes with an area of non-perfusion greater than 5 disc diameters. So if you have more than 5 disc diameters, these are the patients especially that need to be followed up more closely. So the follow-up should initially be monthly. Then once 3 months have passed after the episode, 3 monthly for at least 18 to 24 months. So long-term follow-up, again, as I said, these patients need to be followed up at least for 2 to 3 years. Watch carefully for signs of neovascularization, and if neovascularization develops at any point, then a sector laser photocoagulation should be done to the ischemic quadrant so that an anti-VEGF can be given. Conversely, if you feel that there is a lot of CNP areas and the patient would be lost to follow-up, though the studies do not recommend that, but in our practice, most of us in practice do a prophylactic laser even before the new vessels have developed, provided there is very extensive capillary non-perfusion. Now again, this patient has undergone laser photocoagulation. Like, these patients need to be followed very carefully, and you see still there is that big frond still present, and there is still an area of ischemia in the periphery. So your laser has to be done very carefully. You have to laser all the non-perfused areas. Otherwise, this patient, you're lulled into a false sense of complacency. You feel, I've done the laser, this patient is safe now. But till your laser is complete, you see this patient has a big frond there and could bleed any time. Now, TRDs occur due to fibrovascular proliferation and incomplete PVD. So a lot of these vascular occlusion patients in the long run, if they are not lasered, would land up with a tractional detachment. And this tractional detachment can cause either retinoschisis or later a combined retinal detachment. Macular changes, macular ischemia, of course, is common, where you see the distortion of the FAZ and you see the disorganization of the retinal layers on the OCT. So this kind of a patient would have a poor visual prognosis. Other macular issues would be epiretinal membranes and macular holes, both lamellar and full thickness. So epiretinal membranes, again, are extremely common after a vascular occlusions. As we know, most of the epiretinal membranes are idiopathic, but in a lot of patients, if you look very carefully, a patient with epiretinal membranes, if you look very carefully, you'll see telltale signs of a BRVO which has happened in the past, like these telangiectatic corkscrew vessels, a few hard exudates, very subtle signs you'll see, and epiretinal membranes are very common after vein occlusions. around 14 to 16% would develop, and these membranes will exacerbate the macular edema. So this is a patient with ERM. Post-surgery, you see this membrane has been cleared. So this was a patient with vitreous hemorrhage. The patients with epiretinal membrane tractional detachments would require surgical intervention. And these are the cases where you would need to do, since they are very long standing, the ERM is pretty tight. These are the cases where when you're removing the ERM, you have to do it very slowly. It's attached to the disc. There could be some amount of vascularization over there, so you have to be very gentle so that you don't induce hemorrhage from the disc when you're pulling this membrane off. And because of these long-standing ERMs, the retina is thrown into folds. So many a times you have to combine, in these post-occlusion cases with ERM, you have to combine it with an ILM peeling as well. So this is again another patient who, this is again 1 year after he had the vascular occlusion. You see that he's developed this taut posterior hyaloid which is vascularized now. So it is like a vascularized ERM. This is the OCT. And on surgery, this whole membrane came up along, when the PVD was induced, this whole membrane came up along with that. So, in conclusion, BRVO can have a myriad of late complications. Close follow-up in the initial years is extremely important. You have to counsel the patient accordingly. A combination of laser, intravitreal injections, and vitreous surgery may be needed to restore vision. Visual gains after surgery may be limited by the photoreceptor damage due to ischemia or long-standing macular edema. So, thank you so much.
Very well summarized, Dr. Bali. Just to add on to this, as you've very correctly pointed out, that these cases are about 14-15% associated with ERMs. And when you counsel these patients for ERM surgery, one really needs to know about this underlying cause, and the patient has to be told, because prognosis is poorer than the idiopathic ones.
Very well,
and once you're operating them for a combined RD, you can have a very bad hair day. These patients behave very differently, and some of them really give you nightmare on the table.
True, true.
Yeah, just one last question to you, ma'am. What about these recalcitrant NVEs which persist despite very good sector PRPs in BRVO cases? Any use of adjuvant
Yes,
anti-VEGFs?
definitely. Anti-VEGFs do have a very, very good role in such cases. If there's a very prolific new vascularization, then you do need to combine it with anti-VEGF agents as well.
In the same sitting, or you inject anti-VEGF first or followed by treatment?
So see, it varies from case to case. If I feel this patient has very large new vessels which could bleed before the laser takes its effect, I would start with an anti-VEGF and then follow it up with laser. If the patient has flat NVs, which I feel are not going to be bleeding, then I would start the laser, and if need be, if there are any residual new vessels left after the laser, then I would do an anti-VEGF. So it varies from case to case. But then I would definitely do a combination if the situation arises.
Thank you, ma'am.
Ma'am,
So-
just one doubt. While you are doing a BRV and a PVD is not induced, so do you prefer inducing the PVD over the ischemic retina, like the post-BRVO retina, or would you like to go the other way around? Because what I believe that the retina is very atrophic where the RVO has happened. So what is your surgical approach, and how do you prevent any iatrogenic breaks from happening over this area?
No, the retina is thinned out, but it doesn't really, create holes over there. So I do the PVD the usual way from the disc onwards, yeah. Unless it's a very, very long-standing tractional detachment, then it creates a problem. But otherwise, the ischemic retina doesn't really.
Now, this is what I was mentioning. The vitreous is very adherent, retina is thin, and you really can create iatrogenic breaks.
this happened with one case
Yes,
too.
it happens. It has. This is why I said that these cases of hemorrhage should not be taken lightly. They can give you nightmare on the table, especially if the patient is faking.
It goes into combined
The
RD
patient
and
is
it's-
faking. The combined RD is already there.
Yeah, right.
So, but now you're developing one break after the other, and there's a lot of bleeding. So it gives you jitters.
Thank you.
So hence we conclude the session, medical and surgical retina. May I call upon all the speakers for a group photograph?